Like I always do around here, we start on time and we end on time, and we're going to cover a lot of territory today. Welcome everybody to Interop Workshop. This is a technical discussion with regard to healthcare data exchange and facilitating that interoperability overall. Our catchphrase is, and I guarantee you that it is true, this is the most fun that you will have and still be talking about healthcare data exchange. I guarantee it. You just can't have more fun than we're going to have for this next hour and be talking about this topic. Um, I am your host. My name is Jim Benson. I'm the CEO of Zen Healthcare IT. And with us, as always, is our resident expert. We call him Mr. Wilson. Sometimes we call him the Ron, and sometimes we call him the Chomp as well. And we're going to see if our guest can stump him today. But he's batting 1,000 so far. So and we've only been doing this for about a year, year and a quarter, something like that. So he hasn't missed one yet. So we're going to see how our guest can help us with today. Ron Wilson is our VP of interoperability and our solution architect here at Zen. So he knows an awful lot about our product suite overall and what we do. And as a result, he plays a lot of time in our clients' environments as well. Today we have a special guest for those of you who've been on this previously, and I'll tell you who that is here in just a second. I also want to recognize Jessica Shaw for helping us get this thing all coordinated and advertised and available to everybody. We appreciate her hard work on that. The little bit of background with regard to, again, for the new kids on how we do this. This is a real world discussion on interoperability challenges. We invite everybody. You don't have to be our client. You don't have to be a prospect. You can be one of our competitors, vendors. It doesn't matter. This is an open discussion here. And I mean that literally. This is an interactive discussion. It's open mic. If you were here just a little earlier, you know that the microphones are on. Everybody likes to turn the microphone off, and I appreciate that, but do not hesitate to turn it on. And I always do encourage people, turn on your cameras, and I don't mind. We look in the side of people's heads all the time. It's no big deal. When you do that, it's helpful to put a face with a name. You may recognize somebody that you know before, and like Jessica has done, and I see people are doing it. Please introduce yourself in the chat here. You never know where you're going to find a new friend there or somebody that can really help you here going forward, and that's the point of the whole thing. So do introduce yourself there, please. It's a great opportunity to let others know about yourself and the company that you're with and what you do. This episode, as most of them have been, but we are going to do expand on this, is sponsored by Zen Healthcare IT. I'll put a shameless plug in every now and then, but it's not an advertisement for us overall. But we do want to have everybody know of our Fire to CCDA and CCDA to Fire transformation services. So if you've been struggling, or you know that the need is coming up to do translation between those, please don't try to reinvent the wheel on that. Reach out to us. Just throw a Slack in here, or excuse me, a chat in there if you want to. Reach out to us. Otherwise, if you want to put something in the chat and we'll follow up with you on it, just say CCDA in the chat, and we'll do that, and we'll move on here. So, but we appreciate the. I'm doing it, but I appreciate the sponsorship, and you're listening to that little commercial there as well. Finally, for that introduction and the preamble here, we do have, as I mentioned, we've been doing it for some 16, 18 months, something like that. And we started in 24. Yeah, actually, it's longer than that. We started in 24 and 25. All of those episodes are archived out on YouTube so that you can get to them. There is a list of topics that we have done. Some of them are, not maybe not so great, I'll say, because I can say it myself. But there's some of them that's got a lot of meat on the bone there. Jessica, if you will, throw the link out there to the YouTube page if you want to click on that and use that for a little reference there. You may find some discussions that are really worthwhile there. So I encourage you to at least check that out. There's some good stuff there. Appreciate you doing that. Before we get to the discussion here in detail, I also want to mention that our own Ron Wilson is going to be participating in the CommonWell Summit 25, which is coming up here in September. Just not too far away. That's the 22nd and 23rd in Indianapolis. I'm going to let Ron give the 411 of what you're going to be covering in that, if you will.
Been working with the CommonWell technical work group for the fire project at CommonWell. And I think we're going to be talking about some of the new features and functions that are coming there in implementation of B2B, B2C data exchange. And we're doing some testing and implementing a new implementation guide. So some new things coming. So I might be getting a little precursor there on the drop, but that's basically what we've been working on. So.
And Liz, who happens to be our guest today, just dropped the CommonWell Fall Summit link in the chat room. So please look at that and check that out as well. There will be a lot of good stuff there. And in full disclosure, Zen is a service adopter of CommonWell here. So if you're trying to get on CommonWell, remember Zen is your new best friend. So with that in line, let me introduce Liz Lewis. Liz is the director of director of product for CommonWell Health Alliance. She leads, I'll do some reading here. She leads the execution of CommonWell's vision and roadmap, expanding new use cases. She is a member, and she's going to correct me, she may be the chairperson of the Sequoia RCE committee, the recognized coordinating entity. She's also a member of Care Quality's advisory board. She started out her health journey with in her dad's cardiology practice, doing the transition from paper to electronic charts. Geez, that's my vintage. So she must have been about 3 when she was doing that. But she served as the product manager of interoperability solutions for Greenway, which is also a founding member of CommonWell. She's led the development of the integration of CommonWell services to the energy platform for Greenway, and she chaired their Alliance development, deployment and utilization committee there as well. Liz holds an MBA in data analytics, a master's degree in communication, and a BS in communication as well, which will come in very handy in this discussion with Ron and myself for a little joke there. She's in home is Wilmington, North Carolina. So not only is she very busy, but you would call Liz a heavy hitter in this space. Liz, thank you for joining us. Welcome.
Thank you, Jim. Thanks, Ron, for having me. Excited to be here. Dig in.
Thank you.
Let's dig right in, folks. Let's see how long did it take me. 8 minutes, and that's what I had on the.
There you go.
There you go. It's perfect. So, Liz, I'm going to start out with this one. You, along with your some counterparts there, spent some time in Washington here recently at CMS. Are they really behind this effort overall? I will say, without getting political about things, this administration's history with regard to healthcare initiatives is not necessarily stellar. Are they serious?
I mean, that's a great question, and I think a fair one, to be honest. You know, again, without getting into politics, I think we've seen a lot of like hurry up and wait across the board with various initiatives at the federal level, all, you know, around interoperability. We obviously saw a really big push out of the last administration that actually got TEFCA to be somewhat real. So it's a fair question. It certainly feels like it will be real in the near term. So we are already seeing movement. I've seen this group at CMS work very rapidly to put things together. And, you know, there's going to be critics across the board, I think, from all angles. There's going to be people who say they're going too fast, it's not well formulated yet. And then there's going to be people that say, you know, things aren't happening at the speed with which we want them to happen. And both things can be true, but somewhere in the middle is reality. So I do think it's going to be real. I think that they have successfully so far brought together some really strong players to represent these different pledge categories of like CMS aligned networks and patient facing apps, and there's some real power behind the folks at CMS right now with regard to getting these things off the ground. Only time will tell, right, with how quickly we'll see real progress take place, because we sort of made these pledges of, yes, we believe in these things. Yes, we want patients to have access to their data easily. Yes, we want to have, interconnected networks that function seamlessly without heavy lifting. And Ron's laughing because obviously there's always heavy lifting, but we'll move the burden around. But I think time will tell sort of how long it takes to get these things off the ground. But I am already, so we were in DC in early June, just starting to talk about this. And then by end of July, we were making a pledge. I'm already seeing movement with these organizations starting to collaborate and work together. And one of the key differences that I'm seeing is that some of this is happening a little bit more organically than how things have sort of been handled more prescriptively on the ONC, ASTP, TEFCA side of the house.
And
So we'll
I was
see
gonna ask you that.
how it jives.
Sorry, I didn't mean to step on you
No,
there.
go. Yeah.
I was going to ask you that it seems to me that it has that these efforts have kind of hit critical mass and they're moving forward on their own. Now, obviously, CMS can impact things very dramatically one way or the other. But if they were to just leave it alone, the ball's rolling.
The ball is rolling, but I think there are still some groups who either are unaware of the very real challenges that exist, especially in the patient access space. The ball is rolling. So 5 years ago, patient access was nowhere near what it is today. There was essentially no exchange happening where patients could access a national network and get their data. That is changing. We are seeing real movement in the right direction for patient access. But there are definitely still some groups that are not participating and not coming to the table. And I think that, there's a part of CMS stepping in that's sort of forcing their hand, because otherwise I, as a big player, like, I have to be at the table. If CMS calls me to the table, I'm coming to the table. Yeah. And if this is what they're saying, I mean, it's, are you going to jump how high?
Okay, but you just said some are not. Name names. Who's not?
All that I'm going to say right now, I think that the people who are working well in the patient access space are new, leaner, startup, post-startup mode vendors.
Yeah.
Right.
And Liz, aren't we going to see some folks from ASTP at the summit? Isn't Dr. QHIN going to be there?
Yes, Dr. QHIN will be there. And Dr. QHIN was there at the CMS event and spoke as well.
Yeah.
And they're certainly working towards some alignment between these initiatives.
I mean, what I was excited about the announcement of Dr. QHIN was he is a data exchange guy, and he is very involved with, the Maryland HIE CRISP, right? So it's really in his wheelhouse to make sure that we are exchanging data. So that was promising for me when they made the announcement.
Yeah. Fantastic.
Agreed. Yeah.
All right. Moving on here. Treatment. What is treatment? Now, that for most people, and certainly if you're not familiar with what's going on with it, you may be scratching your head going, well, that's kind of a stupid question right out of it. But it may not be, depending on your answer here. And give it a little history, and I want you to correct me where I get this wrong. Formerly the HIPAA definition was what everybody used. Under TEFCA, it is changed, it's redefined, and a lot has to do with whether you're getting compensated for it, the definition of required treatment versus treatment, which makes most people scratch their head real good. Talk with us a little bit about where we are right now, and especially things like various entities' interpretation of required treatment, and what the difference of those is, and how it affects the people that are on this call. Why does that make a difference to them?
Well, it makes a a really significant difference. And I would say if you would have asked me this 6 months ago, I wouldn't have all the data I needed to feel really super confident in my answer to this question, but I do today. I have hundreds, if not in the, in the low thousands range right now of organizations that are, employ licensed healthcare providers that have credentials that see patients and treat patients and prescribe medications and all that entails, who do not meet the definition of TEFCA required treatment, and therefore are unable to meaningfully, keyword, participate in TEFCA treatment exchange. The reason for that is the definition of TEFCA required treatment at its core boils down to, if you meet these certain categories, then if you make a query, others have to respond to you. This is the key, whether you have to respond or whether you should respond, right? And so the definition of treatment under HIPAA, which is what national networks and frameworks have been using for a long time, now has become you should respond. But anybody in technology knows that if there's a may or a should written into the specification, that we'll get to that in phase 2, maybe, or maybe never, right? But we're going to build to the requirements first, and that's what we're going to focus on. And this circling back and evaluating of whether we should incorporate any of those shoulds or mays oftentimes doesn't happen. And so most of the organizations that are live on TEFCA are not going to be responding to the HIPAA definition of treatment. We've been in the process of getting organizations into our new platform. We built a new platform over the last 2 years. It's here. We've successfully completed like 95% of the migration at this point in time. So our legacy platform is about to be dark here in the next month or so. And that's super fantastic. But as a part of that, it has opened up the gate as far as re-reviewing organizations that previously have been exchanging within the care quality framework. Organizations that employ licensed healthcare providers that we can confirm and that they do care and treat for patients. But some organizations no longer will respond to those, even over the care quality framework, unfortunately. So where they may have had exchange possible in years past, that has essentially been turned off or turned down based on how you look at it.
Wait a minute. You mean, because I was going to ask you, isn't that an incentive to people to stay on the legacy CommonWell, care quality, and not go to TEFCA until they get this fixed up? They're going to, in essence, downgrade care quality?
Not at the care quality level. There was talk actually of adopting the TEFCA required treatment definition in care quality, and that has not taken place to date. But I will say that Epic has publicly stated that they use the TEFCA required treatment definition in care quality land. And so that's a requirement now. And so we have to provide additional evidence beyond what we've done in the past. And I have hundreds of organizations on my desk right now. We've hired more people to go in and try to find evidence. And there's some that are not, the organization itself is not a covered entity, but it employs licensed healthcare providers. I mean, one of the most classic examples that we see are assisted living facilities.
Yeah.
Assisted living facilities in and of themselves are not covered entities oftentimes. Sometimes they are if they're paired with other types of healthcare settings, skilled nursing, and such. But in and of themselves, just an assisted living facility is not necessarily always going to be a covered entity, and therefore cannot participate in TEFCA, despite the fact that it has humans who are licensed healthcare providers who provide care for patients in those settings. And they will not be able to have access to data that they rightfully should. So this is something we've been fighting for. Some of our counterparts, some of our competitors in the space, quite frankly, like I'll name them. They're friends of ours. No2 and Health Gorilla specifically, those two, and CommonWell, we've sort of teamed up together to to try to provide real examples of why this is damaging healthcare by constricting the definition in this way. And we get it. Like, don't get me wrong. Trust is at the core of what CommonWell does. Like we have said for years, we have 4 core services and one of them is trust. And so we do not feel in any way that we want to invite any sort of bad actors who are coming on the network to do things that are not treatment on the network, right? And we interrogate people, right, to make sure that that doesn't happen. But
I can
yeah.
testify for a fact that you do because we experience it. Yes.
Yeah, we deal with it. Say, Liz, Mel's got a question here, Solace, for air quality. Maybe Marilee can chime in here too a little bit. Do you guys believe that care quality is going to move to a more unique and restricted version of the definition of treatment in general to align closer to TEFCA like they're doing with DOA? Or what are you guys' feedback if you can't give any?
I mean, at this point in time, I am just simply not sure. The
Yeah.
conversation has been there. We have absolutely talked about it just transparently. Like it has been on the table. We have reviewed the definition in, Jim mentioned I'm on the Care Quality Advisory Council. Yes, we have talked about it. It was not approved to move forward at this time. And we provided really strong feedback and No2 specifically provided some really exceptional data-backed feedback as to why this would be damaging to do. So as of right now, it has not, but that's not to say that it wouldn't in the future. And the thing with care quality is any care quality implementer can create their own business rules. And so an implementer can create business rules that restricts exchange themselves. And so that's what we've seen. That's what we've seen Epic do. And they, in the care quality framework, have a right to do that, whether we like it or not.
Yeah.
Yeah. Marilee's saying here that Epic's effectively already done it, right? We're already battling that with the business to business definition when we onboard somebody. Many of our clients here today, if you're onboarding a DOA or OBO and things like that, you're already fighting this fight, right? In some form, because you have to do the deeper vetting and provide info.
Any new entry
Yeah.
that wants to exchange data with any Epic facility under treatment, under care quality, you will have to prove a covered entity status. And we are making sure with every one of our customers with new entries that we're doing all that vetting ahead of time and helping make sure they have the right evidence together. And there are some, I think Ed posted, you have to basically be doing HIPAA type transactions. There are HIPAA transactions that are not claims. And so, usually we're able to find that, they are doing some, they just didn't really recognize they're doing it. And we're just presenting that evidence to Epic.
Right. That is correct.
When we think about the other use cases relative to some of these, assisted living facilities, where in TEFCA do we think they're going to fall if they're not required treatment capable? Is that going to fall into the care coordination case management use case? Is that where folks thinks that's going to end up, or how will those folks participate?
We have some that are onboarding for the HIPAA definition of treatment at this
Okay.
And I actually had our team run some stats on those, and they're getting some data. They're not getting all the data back that they could, but it's not a zero. So, for now, where it's not easy or simple, it depends on what they're doing, right? It depends on what they're doing. If they're providing care and treatment, and they meet that HIPAA definition, then that's what's most appropriate. We really see kind of care coordination in the provider space as more of a population health-based type of activity. Now, from a payer perspective, that's different, right? Payer perspective, care coordination of any type or any flavor of care coordination is still in the operations space because it's been made pretty clear that payers cannot payers can't do treatment activities, period. They're not caring or treating for patients. Even under care coordination, it would need to be under operations. I actually was talking to somebody else today about this very thing and trying to get some good data on who's responding. I will call out one QHIN that is responding, at least, anecdotally, to use cases beyond treatment, and that's Kanza National Network. They feel really strongly about providing access beyond treatment, and that's been sort of baked into who they are and how they operate their network. And that's really fantastic. And we hope to partner with them more closely, sort of as we get over this initial hump of just trying to get people on to explore these additional use cases.
To drive that point home, we talked about the taking care of our elderly, but Mike mentions as well correctional facilities. Just for everybody that's on the call, you think about that.
Yeah.
Okay, if a doctor goes, when was the last time you heard of a doctor going to a correctional facility? I'm sure it happens. I don't know for sure, but I'm also pretty sure that those folks get really sick too and have to go. How does it?
Well, they can employ nurses, they can employ providers, different provider types. Absolutely. The correctional facility itself is not a covered entity, but it employs licensed healthcare providers who provide care, who provide treatment plans, who provide medication to people who are incarcerated, and they have a right to healthcare too, in this country. So there's that. And then the big one that I'm finding very, very frequently, and I don't know if you guys have seen this on sort of the social media of healthcare landscape, but there's been a lot of social media noise around insurance and challenges with providers, right? Just getting things approved and getting things paid for. And unsurprisingly, there are a lot of direct primary care and concierge type of entities that exist.
Right.
And these are, again, like licensed providers, MDs, PAs, right? Nurse practitioners, who provide care, but the patient doesn't have any need to interact with insurance, and the provider may not participate in any HIPAA standard transaction. And so they're out. They can't get them on easily.
Crazy. So some of these things, do make sense, and others are you scratch your head and go, what? So just sum it up for a second, and I'm gonna move on. What's going to happen?
Well, people like us and Marilee, definitely, we have continued to have difficult conversations in all sorts of forums. We've continued to use data to explain the story of why this is a challenge and why this isn't what we had intended to have happen, with this sort of putting guardrails in place to make sure that bad actors don't come in. That was the intent of creating a process to review organizations before allowing exchange, was to try to prevent bad actors collectively as a community, prevent bad actors from coming in. And I think that's a good thing. And I think that we should continue to do that because it takes a village, right? And it is difficult. And we have seen organizations hire an MD to front, some other operation in the back. We don't want that, right? But this is not the answer either. And so I think that it just takes some strong voices in the space, and we've already made that case. CommonWell, we've talked to ASTP directly about this, and we do think that our voice is being heard. So in the TEFCA space specifically, we're working on getting a new work group set up to reevaluate this definition of treatment and reevaluate what requirements come along with it, so that we're not excluding necessary parties inside of the healthcare continuum because of the constraints that have been put on it.
Yeah. And
So,
the data
we will make progress.
yeah. And the data that those entities collect is important for people to have as well. So
Absolutely.
we
Absolutely. And they're willing to share that data back, right?
Right.
And they should.
Yeah. Now, I'm going to move on to a slightly different thing and come back around to this. So we get the QHINs today. Again, you correct me if I've got bad data here. There are 10 QHINs that are established today, and I'm counting 5 of them being like Epic or providing a software or service, and that comes along with it, such as, if we got Epic, ECW, NetSmart, SureScripts, and Kanza. You can debate the ins and outs of the different ones, but for the most part, you're going to be a user of Epic or ECW in order to participate to that QHIN. That leaves 5 others: eHex, CommonWell, MedAllies, Health Gorilla, and No2 that we know right now. In addition to Care Quality, which of course is a framework and will not ever be, at least as far as we know, is not going to be a QHIN. Is all that accurate, or am I coloring that a little incorrectly for the audience?
SureScripts is the only one that does include other vendors underneath of it. So SureScripts has some EHR type vendors or other sort of digital solutions that can, similar to CommonWell, right, join and participate through. But otherwise, no, yeah, it's Epic and NetSmart and ECW and
No2?
said one more. No, No2
Is Kanza closed too, or aren't they open?
No, Kanza is just really based on who participates in their HIE.
They're HIE. Okay,
So
yeah.
it's really their HIE participants, which a lot of times leverage EHRs that are connected in other ways. And so we've worked really collaboratively with Kanza to say, oh, you've got that one, even though they're an Athena Health client, and they could onboard through us or they could onboard through you, and we have to kind of figure out where they're going to go. They've been really great to work with there.
So we're going to get to the new exchange purposes in just a second, but Ron, you had put a question in here with regard to, now we got one foot on the boat and one foot on the dock here as it comes to care quality and the migration. And we've certainly gotten a lot of notices from you with regard to people that are changing over here overall. Ron, your question with regard to the MPIs and care quality.
Yeah, I mean, CommonWell, we've been kind of talking about what features and functions are distinct between the QHINs, right? And what are the benefits for one QHIN over another? And one of the things that we know CommonWell has is an MPI. And so is CommonWell today correlating patients found in the care quality network into the CommonWell MPI? So that, if I query through CommonWell out to the care quality network, I go to some site, Ron Wilson, get a found, that comes back, you're adding that correlation into the MPI for that care quality entity, right?
Yeah. So we have this sort of inside CommonWell, outside of CommonWell linking mechanism. So inside of CommonWell, our MPI and our RLS really work together to say, here's the patient, and here's the care location where that patient has been seen. And it creates this index of a human being. So there's just one of me, but at, I live in Wilmington, North Carolina. So at Novant, there's an instance of Liz or Elizabeth really as a patient, at Wilmington Health, at my dermatologist office, at the surgical center where I was just seen, right? So all of these different places have a local instance of my patient record. And so our MPI is able to say, yep, we know Elizabeth Lewis at this address has been seen at Wilmington Health. And similarly, because in the external framework space, like care quality, there's no centralized NPI or RLS. When we get a positive patient match found through an XCPD, a patient discovery transaction outbound, we remember where that came from so that in the future we know to go back to them and target them, right? And are totally okay with people doing that to us too, because we want to search smarter, right?
Yeah.
Not harder. And so I always like to tell this example to people to just sort of like put into scope what it means to remember where patient data is versus just asking the question over and over again. And Ron, I have to just bring up the fact that when you guys first implemented CommonWell, you were like, wait a second, you're not sending us XCPDs. No, we're not. We think about just as from a human being perspective, right? I'm Liz. I live in Wilmington. Say there's 100 provider organizations in a set mile radius around me, right? I've been seen at 3 of them. I see 3 doctors
Yeah.
regularly. I am a generally healthy human being, and I don't get hospitalized a lot, whatever. That means that 97% of the time, when you do XCPDs in my geographical radius of where I live, you're going to get no patient found. And you're going to continue to get no patient found every single time.
Right.
Because I didn't go there, and I don't plan on going there, and I probably never will go to those places, but I'll continue to go back to my 3, and maybe I'll add a 4th, from time to time. And so we feel like informing the NPI versus just blasting people with searches constantly is a little bit of a more effective way to do it.
And so in the concept of PCDH, right, patient-centered data home. So let's say Ron is in Florida and breaks his ankle and ends up, going in, getting fixed up, coming out, and that ends up being found in the CommonWell network somehow. You would store that correlation also.
Of course.
Okay.
Yeah, it's not in CommonWell, there's no regionality or geography base to remembering where the patient is, right? It's based on the fact that you're Ron Wilson, here's your address, here's your birthday, here's your information, and our NPI can go, yep, we know who he is. We've known about him. We know he's been seen at these other 3 places. Boop, now we got a 4th.
And this is going to happen when the QHIN traffic too, right?
Yes.
Okay.
It's a little different in the QHIN space, the way that it works between QHINs, but yes.
Okay. Because I mean, are you gonna have to query the 9 QHINs to get the info, or will you be able to retain that and know it?
Both.
Okay.
Right now, everything is QHIN to QHIN based. So unlike care quality, we don't fan out to endpoints, across the geography. We just ask each QHIN every single time. The key challenge is that when TEFCA was in its, nascency long ago, it was assumed that every qualified health information network or QHIN would have an RLS.
Right.
And that requirement got dropped in the
Right.
actual QTF that exists today. And so not every QHIN has an RLS. And so some of them, there's 3 general models that we know about. The first model is the QHIN has an RLS and knows where the data is inside of their QHIN. The second model is the QHIN does their own geofencing type of search inside of themselves. And XCPDs to a radius inside of their own population to figure out where there's data in real time. And then the third model is the QHIN fans into their entire community every single time, right? And so that's not that third one isn't terrible because it's going to get you the data, but it's sort of abusive from a technology
And it's going to be
perspective.
slow. It's going to be inherently slow, right?
Well, we could have a whole other session on time.
On performance, right? The
we
slowest
can't even
gazelle.
Go down that path today.
Yeah, we call it the slowest gazelle problem around here, right? So, from our perspective, we're excited about the prospects of CommonWell and opting into care quality via CommonWell, because we have many clients that are hunting data, and we have features that allow them to say, I'm going to query, this patient's got an address in Texas, they got an address in Michigan, let's go query 8,000 facilities on care quality and, go do the discovery. Yeah. And it's the only way it will work, right? It really is the only way you can know until you go do that once and then, store the correlation yourself and then re-hit, but then you always have the question in the back of your mind, have they gone to a new facility? So when should I hit their home base, And when you talk about snowbirds, which is a common pattern between Michigan, Ohio, Texas, Florida, they're half the year they're in one state, half the year in another state. So anything could happen in that half year, right? So the idea of this MPI, I think, is really powerful that most folks really haven't grasped the benefit of yet.
And the beauty of now in TEFCA is we're anticipating an update to the spec that will allow us to do targeted queries. So
So
we
on
will,
that,
for those we know about, we can just go to them directly in addition to going to the QN and tell me more, but I know I want to definitely go to these places.
on the Athena migration, recently, you guys took Athena from the old school platform to the new school platform.
Yeah.
Athena used to be an aggregate responder, meaning I would hit one endpoint at Athena and I would get data from wherever. And I fought this fight because I had people going, Ron, we got a problem. This isn't my patient's data. There's no way. I didn't query that. No, it actually is true. They saw a doctor in Key West, Florida by
You
happenstance.
just didn't know about it.
You
Right.
didn't know about it, and they were on Athena. They're changing that pattern now then, apparently, right? Because of the targeted queries.
Yes. Yes.
Okay.
So we're able to target more specifically, but at the same time, because they're feeding our MPI every day, all day long, we'll still know about where the patient's data is.
Individual
Just
sites.
individual sites, it'll just be like the CommonWell MPI versus the Athena MPI.
Perfect, perfect. Some folks don't care, but other folks do, right? They're asking for data from Dr. Bob. They don't want to, drink from the fire hose for data from, Dr. Sally.
Of course.
Right?
Yeah. Well, and now we're at a point in time where, and we spent the first half of this conversation talking about people still need access, and that is still very true. But for people who do have access, there can be a lot of data that they can get back, and that can be overwhelming. And so it's almost like, well, this is too much. I can't do anything with it. I'm not even going to look at it. So targeting specific organizations has multiple different valuable uses to explore.
Completely. Well, good. Thank you.
Okay, we got new exchange purposes that are coming January 1st, 26, which is scarily right around the corner here. Generally speaking, what are they, and what's CommonWell's level of seeing the level of interest in them at this point?
So I think you're talking about the healthcare operations ones. There's some sub-use cases like care coordination, HEDIS, and quality measure reporting that are coming in early 2026 as required.
Yep.
I expect those to get pushed. So you heard it here first.
Okay.
Or heard it in other places. But I do not expect those to stick because I have not seen movement on them. From our perspective, we actually wrote a use case over the summer to try to encourage more of this type of exchange and bring in new types of organizations. And that is called Choose Your Own Trade Partner.
Are you looking at my notes? Because
No, I'm not looking at your, am I segueing already?
Go for it.
Yeah, no. So at least from my perspective, in order to get something to a required state, we have to see it actually work first. And we haven't really done that successfully. There's some exchange happening for these other use cases, but it's not being you talked about the fact that I had a degree in communication, so I'm going to just pull that out now. We're not providing the value statements, right, around this type of exchange in a powerful enough way to increase adoption. There is some of this exchange happening, but it's, not frequent. And it's very concentrated between parties. And so we thought, let's go ahead and just create that space publicly, where organizations can agree to participate with others, and hopefully increase the feeling of trust or increase the reality of trust within the network before we get to something being required. So we have 10 purposes of use or something like that. Some of them are kind of granular, like care coordination under healthcare operations. Some are just more broad, that we have opened up. We're in the process of creating those controls right now in our system, and then we're going to be piloting that in Q4 of this year. so that we can say, okay, provider organization A and prior authorization vendor work together, and instead of faxing my clinical documentation, I'm going to agree to let the prior authorization vendor query me for that clinical documentation to fulfill the prior authorization workflow, and get the data they need to say yes to this medication or this procedure, right? So that's kind of step one. And I think once we start to see movement in that space, we'll be able to talk about it again, like bringing back to, you got to have some data to tell the story. I'm not going to just like trust and believe you. I want to trust but verify. And so we want to make sure that we have that data available to push these things forward.
Is that one of the things that is going to separate care quality from all the other QHINs, and you're going to be the better one?
Potentially. I mean, we try to do things in a really consensus focused way. That's just our nature. I mean, we're a trade association. We bring together competitors to try to make Interop better. I mean, that's been our mission since day one. Well, really, our mission is like breaking down barriers to exchange and yada yada yada, all the important marketing terms that you have to say. But in essence, that's really what we do, is we bring together competitors. And I mentioned some, like Health Gorilla is a member of CommonWell. We work together. We compete with them in the market, but at the same time, we have shared goals that benefit all of our clients across the board. Similar to Zen, right? You guys are a connector, and we talk about that openly, and we encourage that, right? Because at the end of the day, we want to make sure that we are enabling exchange whenever appropriate, so that patients and providers, and hopefully, payers as well, can decrease cost and get patients the, information they need, get them the access they need, and have the best outcomes they need.
Right. Now, obviously, I'm just poking you with some of these questions, that, but from our, the people that are on this call's perspective, choosing a QHIN is a big deal. It's more than the cost of signing up. It is the infrastructure. It's dealing with Zen, because obviously we're the organization to deal with to get onboarded. All of those things. It's not something that is easily changed, and yet what we're going to see in the marketplace is the different QHINs are going to have different characteristics. They're going to have different features and functions. The EHEX is going to, attack the record locator service concept differently than CommonWell, and a whole host of other characteristics there. How is the end user, the tech vendor that is establishing themselves today, how should they be assessing their opportunities in the marketplace and not waiting until it's all fleshed out and all their competitors are already connected, because it's not an easy process to go through? What's your recommendation on how they attack the problem of picking the right QHIN?
Yeah, it's a good question. And I'll say, from what we've been doing this for many years, because even before there was this like shopping for QHIN model, there has been care quality and, competitors in that space as well. And this is not a, one size fits all. The different QHINs have different services that they offer. We are much more tuned to large scale, large volume. We are not so much like the concierge type of entity that, quite frankly, Zen is more likely to be. So from just a pure, QHIN perspective, we really pride ourselves on, again, the MPI RLS being at the core of what we do. We do not send patient discovery queries to our members, to our connected organizations. We handle that and buffer that exchange for you. And there is a buffering to it, that is a brunt of computing power, that we have to take on. And we definitely look to bring on board relatively, moderate to experienced type of interoperability solutions. So we are probably not the most appropriate QHIN for if this is your first interoperability project that you've ever done, right? This is probably not the home for you. There's probably other QHINs who could make the process a little bit easier, but we provide access to a very large internal network of CommonWell, as Ron was sort of alluding to earlier, of, we remember the links inside of CommonWell without even having to go outside. So from that perspective, but definitely there's multiple different flavors and multiple different price points across the board for people to examine. But I think our stance for the past 2 years or more has been, find your home and get connected, because ultimately, your clients should be able to get data, right? And we want to make sure that they can do that.
Absolutely. It's really important. I am watching the time. We have about 10 minutes left, and there is one topic that I know that is important. Certainly, it's important to Zen and what we're doing here, but it's certainly also important to an awful lot of the people that's on. I think it's important to you as well, and that's the IAS, or individual access services, that is so vital. Ron alluded to a little while ago, okay, I was in Florida, I needed this thing over here, but I need to make sure that I need to keep up with my wife's history. If she has a problem, I need to have that current history. That's an individual access use case. Talk to us a little bit about what CommonWell's attitude is on IAS and where we're going, because hopefully it ends up being very easy for the patient or the caregiver ultimately, but there's a lot of steps in getting it going. I just want to open the floor to you.
Yeah, well, this is one of my favorite topics, so thank you for bringing it up. So CommonWell wrote a patient access use case in 2016. So we're almost at the 10-year mark of supporting this as a use case. When our executive director, Paul Wilder, and I both came on board, we both came on board about the same time in 2019. We started really digging into it, and we naively thought that it was just ubiquitous and everyone was doing it. And that was not the case. And so we dug in and found that only about 5% of our network was actually responding to patient access use case. And that was a shock. And so we have been on a 5+ year campaign to bring education, to strengthen specifications, to strengthen policy, to strengthen technically this use case. And we handed over our specification to ONC when they were drafting TEFCA and said, here's a starter for you. Here's how we think that this should be done. And IAL2 came from our specification. The requirement to do identity verification came from our specification. And so it's something we're really proud of. And it's something that now today at CommonWell, we have like 80% responding to IAS. We've been really, really loud about it. There are still hurdles. So in TEFCA, and Marilee and I know she had to drop, but Marilee and I have gone round and round and round on this topic. She and I could just like sit down, for hours probably and go to town on this one. But TEFCA says that you have to respond to IAS, or individual access services, or what we call patient access. It's all the same thing to me. It's an individual having the right to access their own clinical data using the application of their choice. And we do require that they identify that they, I am who I say I am. But when they do that identity verification, we believe they should have access to their data. So just because it is required does not mean that 100% of all TEFCA entities are responding to IAS. And that's disappointing. They have found some, either loopholes, or they're just straight up not in compliance with the SOP. And so we wrote a white paper about this year. We demoed this at HIMSS this year. And one of the key things that I want to call out here, and if we could just like full circle back to CMS, and one of the things that I hope that CMS continues to push on is that a patient should not have to know their portal credentials to get access to their data.
Correct. That
I'll-
is a BS
Yeah,
deal.
I will share from I've shared this story many times, but I'll share it again really quickly. I used to live in Atlanta. Now I live in Wilmington, North Carolina. Why, you ask? Because of the traffic.
Yeah.
Being really challenging, but really, in all seriousness, when I lived in Atlanta, I had a cancer diagnosis. I was very young. That information is important, right?
Right.
I don't even know that I have portal credentials for the place where I had the diagnosis and had the surgery.
Right.
Does that mean that I shouldn't have the ability to get that data, easily on my phone? I should have been able to get that data 10 years ago, but I couldn't. 5 years ago, I couldn't. Right. And so it's important that we make this available so that I can have access to this. I can remember what happened. I don't know what happened last week, let alone, 8 years ago.
Right.
So the access matters, and relying on having an active portal that I registered for, knowing my credentials, and I'm a I work in healthcare technology. And if I can't do it, there's no way my mother will be able to, right? So we need to
Liz,
make it
isn't that information blocking? To me, that sounds like information blocking.
Potentially. They will say there are other ways that you can get access to this information, and it doesn't have to come through a national network. But if it's very difficult to get access through other ways, it could be considered information blocking. Sure. I think that there's actually a significant amount of information blocking that's happening out there in the ecosystem today.
Name names. Who's doing that?
Well, I mean, everybody knows that Epic is the one who is requiring portal credentials to my chart. And if you dig deep enough, there could be a financial component to it, of accessing my chart. There's a financial incentive there. But we strongly believe that if you have a awesome patient matching solution and require identity verification, that you can do this without portal credentials. And portal credentials from one of our members, I think that they said, I don't want to get their stat wrong, but I mean, it was like at least 70%. When a consumer is faced with having to log into a portal, they exit out the system. They're like,
Yeah.
I don't know I don't know. I have no idea what email I used, what password I might have had. Like, I'm out. I'm not even going to try. I'm just going to exit the program.
Yeah. Well, at Zen, we do have an internal rule that you can make a mistake. That's one thing, but public shaming is also a real thing at Zen. So that's why I ask these questions and go, okay, everybody that's on this call, we got I don't know, some 50, 60, 70 people that are here. Everybody should know, okay, who is doing that stuff? Because
Yeah, and there's others that are not
a
responding, and Epic's model is you have to have the portal credentials, and there's just others who are just straight up not responding. And so we have got to push on some of these people to come up with a better strategy. We will share our patient matching algorithm. We have shared our patient matching algorithm publicly inside of the care quality space. We believe that we should be talking about this, because if that's a concern, if that's making sure you have the right patient and you're not disclosing data to the wrong patient, like, that's important. We get that. But then let's talk about it and let's solve the problem versus putting up a gate that is difficult to get around.
And they're actually creating another risk vector with passing those credentials around from app to app.
Yeah.
Right. When you think about it, right, that application's not going to be a password store or a secret store. It is a localized application that's dependent upon a JOT token coming from the CSP, and all they need to manage is their own application security, not external secrets. Because if one adopts it and then ECW adopts it and Greenway adopts it, before you know it, you're creating a secrets manager, not an individual access services solution, right?
Right.
Well, and a lot of them have been forced to go down this route, right? Because
Yeah.
this is what the patient access APIs from certification gave them.
It's crazy. It's crazy. I mean, I understand why they defaulted to that, but when you look at it on a much larger scale and a practical reality scale of dealing with an elderly patient, an adult or parent or
Yeah,
something along those lines,
absolutely.
your mind blows. Listen, we start on time, we end on time here. We got just a handful of seconds. I want to say thank you very much for joining us here. It's been wonderful, tremendous amount of great information. And I will also put you on the spot and say, would you come back again sometime as we have a whole nother set of
Anytime, anytime. We continue to think up new things and face new challenges, and we're happy to collaborate at any time. Of course.
Yeah, it's fantastic. It's been great. We really enjoy doing this. Ron and I have a lot of fun putting it together with the rest of the team. Again, we're very grateful for you. We will make this available. If I'll leave the chat up for a couple of moments for everybody. If you want the recording of this, or if those notes will help you, just put the word notes in the chat, and Jessica will go through there and make sure that she gets you we do record it and use AI because we're a technology company, and we'll
Why
be able
not?
to get you the information here that I hopefully will help you. We want to make sure that everybody is doing is enabling this healthcare data share. It's important for us all. So thank you very much again, Liz. We'll look forward to talking to you again, and everybody else join us here as well. Oh, by the way, Jessica put in there Interop Workshop for next month as well. We haven't even figured out all the topics yet, but we'll do something cool. I think she's got it there. She's got it there for next week as well. Please join us again. Thank you all. Take care. Bye.
Thank you. Good
Thank
seeing
you
you, Liz.
all.
Thank you. Bye-bye.